Arvind sir? No. We'll give 1 minute, sir, for it to join. Kanna sir.
Namaskar. India has achieved this. This call is now being recorded.
Hello, sir. Sir, Zoom meeting I joined Panyaching, sir. But I couldn't see my slides, sir. How to share my slides, sir?
No. Now you will not be able to see your slides. The other person is sharing, no?
Okay, sir.
You will get your done 1 hour from now.
Okay,
You
sir.
remain in the group.
Okay, sir.
The boy from Coimbatore is going.
Now it is full screen, Ra.
Now it is full screen, sir. Thank you, sir.
Wait.
Kanna sir, can we start, sir? I think we have Dr. Balaji, I think other faculty also joining.
Yes.
Arvind sir should be joining anytime. Anyway, it is 8 o'clock. We will start the session. Good evening, friends. We warmly welcome all of you, the senior faculty here and the invited faculty. We also welcome the students and delegates who are watching in the YouTube channel. So today we have 3 important cases for discussion. The first case is from the Coimbatore Medical College, kindly contributed by Professor Srinivasan sir. It's a case of a mass abdomen, especially it is a liver mass which is going to be discussed by Dr. Malik Nizam. Then we have 2 other cases kindly contributed by Professor Alex Edwards from Government Tirunelveli Medical College. It is a case of basal cell carcinoma. It is going to be presented by Monisha. Then we have oral cancer kindly contributed by Sumati Madam from Government Mohan Kumaramangala Medical College, Salem. So last time the faculty was asking for a little bit about short cases. So the first case alone will have 1 hour. The second 2 cases will have half an hour. Faculty, kindly take note of it so that you can plan your discussions accordingly. So we will, and we have 2 important faculty coming in. Arvind sir from GMC Bhopal and Harinder Sandhu sir from LLM Medical College from Meerut. And we expect Dr. Sumati Madam to join on behalf of Dr. Ashok as he is traveling, he informed us. So let us start the presentation. I will try to get connected to Arvind sir because he called me some time back. Arvind sir should be joining, but I think with the faculty who are here, let us start. Kanna sir, can we start, sir?
Yeah, I think, you can start here.
Yes, sir. Malik, please inform, introduce yourself and then start.
Yes, sir. Good evening, sir. This is Dr. Mohammed Nizamuddin, finally a postgraduate in Coimbatore Medical College Hospital. I would like to thank my professors Lakshmi Narayani Madam and Professor Srinivasan sir for giving me this opportunity to present in this forum. And I am going to talk about, present a case about mass abdomen. Mrs. A 47-year-old female, homemaker by occupation, resident of Coimbatore, presented with chief complaints of mass per abdomen for past 1 year and abdominal pain for the past 1 month. History of presenting illness. The patient was apparently normal 1 year back when she noticed a mass in the right hypochondrium, which is incident since onset, gradually progressed to attain present size. History of abdominal pain present in the right hypochondrium and epigastrium for the past 1 month. It's a continuous dull aching pain, non-radiating type, no aggravating and relieving factor, not related to food intake. History of fever present for the past 1 month. It is a low-grade intermittent type of fever, not associated with chills and rigor, relieved by medications. No history of vomiting, early satiety, no history of hematemesis and melena, no history of altered bowel habits, bleeding PR, no history of yellowish discoloration of eyes and skin, no history of itching, no history of loss of appetite, weight and bone pain, no history of cough, breathlessness, and hemoptysis. Coming to past history, she is not a known case of chronic liver disease, diabetes mellitus, hypertension, coronary artery disease, bronchial asthma, and pulmonary tuberculosis. History of sterilization done 29 years back, no history of previous blood transfusion, no history of medications, and the history of contact with pets is present. Coming to personal history, she takes a mixed diet, not a smoker or alcoholic, has normal bowel and bladder habits, normal sleep pattern. And menstrual history, she attained menopause 2 years back, para 3, live 3, and perpural sterilization done 21 years back. Summary, a 47-year-old female came with complaints of upper abdominal mass for the past 1 year with a history of abdominal pain and fever for the past 1 month, with no history of jaundice, loss of weight and loss of appetite, and no history of altered bowel habits.
Okay, Dr. Malik, you said the patient has a mass in the right hypochondrium.
Go to the first slide.
History.
Yes, sir.
So is that a correct statement?
Yes, sir. Mass in the right hypochondrium.
Malik, can you hear me?
Yes, sir. I can hear, sir.
No, you said in the history that the patient presented with a mass in the right hypochondrium.
No, sir. Abdominal mass. She complained only of abdominal mass, sir.
No, if you are telling about the history, you can only say this mass was in the right upper abdomen or
Okay, sir.
lower abdomen.
Okay,
And you
sir.
know what is the hypochondrium, right hypochondrium, how big it is?
Sir,
Do
very
you have any
small.
idea about that? What is the size of the right hypochondrium?
Sir, no, sir.
Even if there's a gallbladder lump is there,
Yes, sir.
it has to be in the lumbar region to become palpable.
Yes, sir.
Because right hypochondrium below the subcostal margin is very small.
Okay,
The
sir.
left hypochondrium.
Okay, sir.
Majority of the hypochondrium which is there, it is the behind the costal.
Okay, sir.
Okay. So
Okay, sir.
any lump which is there, until
Okay,
unless it is going to the lumbar regions
Okay,
or
sir.
the epigastric region, it will not be palpable.
Okay, sir.
Why did you take a history of previous blood transfusion in your patient?
Sir, any issue of hepatitis, patient hepatitis B infection following blood transfusion, sir?
So can you tell if there's a blood transfusion is there and if the patient gets the jaundice,
Yes, sir.
what are the various times he can get the jaundice? Patient receiving the blood transfusion
Okay, sir.
and the patient is jaundiced.
Okay,
So
sir.
when he can get the jaundice? If it is related to the blood transfusion.
Within a week, sir.
Hmm?
Yeah, short duration within a week, sir.
What is that short duration?
Within a week, sir.
Okay, the patient will have the jaundice either immediately or within few hours or
Yes, sir.
24 hours of if there is a mismatch transfusion is there.
Okay, sir.
Because the hemolysis, he can get the jaundice.
Okay, sir.
Otherwise, he will get the jaundice after about 4 to 6 weeks.
Okay, sir.
If it is because of hepatitis.
Okay, sir.
Okay, so in 1 or 2 weeks, the patient will not have the jaundice because of blood transfusion.
Okay, sir.
Okay.
Okay, sir.
Why did you take the history of itching in this patient?
The patient to rule out obstructive jaundice. Patient doesn't have jaundice.
But if the patient is having the obstructive jaundice,
Yes, sir. There will be
what
jaundice.
symptoms will be there before he gets the itching?
Jaundice will be there, sir.
Yeah, the patient will not the jaundice. The patient will say his urine is yellow colored or
Yellow
he is
colored,
having the
yellow discoloration of sclera. And
Yeah, so once
urine.
that develops, then only the patient may have the jaundice, the
Okay,
itching.
Okay, sir.
Right?
Okay, sir.
Okay. And what is the meaning of altered bowel habits? You said the patient doesn't have the altered bowel habits.
Yes, sir. Diarrhea, constipation, sir.
So, was any change in your patient?
Sir, no, sir. No history of altered bowel habits, sir.
And then you are giving history of keeping the pets. What was in your mind?
Sir, contact with pets, any amoebic liver, hydrated liver disease.
Sorry,
Hydrated liver disease, sir.
hydrated cyst. Okay, you are thinking in terms of the. Okay,
Hydrated.
what other things which can happen if somebody keeps the pets? You know any other parasitic disease?
Sir, sorry, sir, I couldn't get it.
Some long worms which are there in the intestine.
Yes, sir. Sir, I couldn't get your question, sir.
Have you heard the trypanosomiasis?
Yes, sir. Trypanosomiasis.
Hmm?
Yes, sir.
So that is another which can be there in a patient. So apart from the hydrated,
Okay, sir.
and also even the amoebic also,
Yes,
if the
sir.
patient is having, then also you can have this problem.
Yes, sir.
Okay.
Sir, Sandhu sir. You unmute. You are muted, sir. Sandhu sir. Again muted.
Hello.
Yes, sir. Audible. Sir,
What
audible,
was
sir.
the history of sternation? What was the history?
The patient has a history of abdominal mass for the past 1 year and abdominal pain for past 1 month, sir. Hello, sir.
What is the difference between a radiating pain and a referred pain?
Referred pain is radiating pain is seen in acute pancreatitis where the pain in the.
No, I'm not asking.
No.
Sir.
Asking.
Listen to the questions,
Yes, sir.
Nizam.
Yes,
What
sir.
is referred pain? What is radiating pain?
The difference. What is the difference? How will you differentiate?
Referred pain is the pain is referred to same
What is the
dermatomal.
difference? How will you differentiate between a radiating and a referred pain?
Sir, same dermatomal pain in the same dermatomal innervation, that is a referred pain, sir.
And then what is the radiating pain?
Clinically, how can you differentiate these two? The dermatomes are not written, right?
Yes,
This is what sir is
Yes, sir.
asking.
Yes, sir.
Think of few
In
examples and we will
palpation.
come to know. Think of
Sir,
some examples.
palpation. Yes. In appendicitis, palpation we will get referred pain, sir. Okay.
So he is not
Referred-
asking the example. How will you
Okay.
differentiate between referred pain
I'm
and
not
radiating pain?
asking the example. I'm asking what is the difference? How will you differentiate?
Sir,
Basically, you read.
yes, sir. Radiating pain is a patient symptom, sir. Referred pain.
What is the shifting pain?
Shifting pain is pain will be in the same intensity.
No, shifting pain.
Pain will be in the same intensity, sir, during.
Okay. Can you give the examples of these three? Referred pain,
Yes, sir.
radiating pain, and the shifting pain.
Radiating
Give
pain
the
is
example of that.
in pancreatitis, they will get radiating pain, sir. Referred pain in acute appendicitis, referred pain, periumbilical pain will be there, sir.
That is the referred pain in appendicitis. Then what is shifting pain?
It's a shifting pain in appendicitis, sir.
Okay.
You have to
Classical
understand-
example, if you want to give all these three pains,
Okay, sir.
referred pain is for the cholecystitis.
Cholecystitis in the right shoulder, sir.
Radiation pain is for the ureteric colic,
Okay, sir.
and shifting pain is for the appendicitis.
Appendicitis. Okay, sir.
Okay.
Okay, sir.
Right.
Just think of literal meanings of these three words and probably you can differentiate.
Okay.
Referred means you get it at different sites than the original site of pain. Shifting
Okay,
means the
sir.
patient gets shifted from one region to another where there is no pain at the where it was to begin with.
Okay, sir.
Right? And radiating means the pain continues to be there along with the other regions, just like the ureteric colic and all. Right?
Yes, sir. Yes, sir.
Normally, what do you think the cause for the fever in this patient? He's having fever for 1 month.
Yes, sir.
So what do you think the cause for that?
Maybe an abscess in a chronic liver
But in the
abscess.
abscess, do you get a low grade?
No, sir. High grade fever with chills and rigor will be there in the abscess, sir. I'll suspect any infection, secondary infections, sir.
So could you think of any possibility of any diagnosis just based on the history? Lump in the right upper abdomen,
okay,
along with the fever. So give the differential diagnosis for these.
Hepatitis. Hepatocellular carcinoma, sir.
In hepatocellular carcinoma, the fever is so common.
No, sir. No, sir.
And then you definitely saying the history of keeping the pets.
Yes, sir. Hydatid liver disease.
Yes. So one is a hydatid.
Okay,
What
sir.
else it can be?
Abscess, liver abscess, sir.
Which liver abscess?
Amoebic liver abscess and
Which will have a low grade fever.
amoebic liver abscess.
Sorry?
Amoebic liver abscess, sir.
Amoebic liver abscess, yes. So you have to keep these two possibilities.
Okay, sir.
What about the cholecystitis presenting with the lump in that area and also the fever?
Yes, sir. Cholecystitis can be.
That is also a possibility you have to keep.
Okay, sir.
You can go on the examination now, yeah.
Yes, sir. A general examination. The patient is examined after getting consent. She is conscious oriented, moderately built and nourished, weight 62 kilogram, height 165 centimeter, BMI 22.7. Patient is afebrile, hydration is fair, no pallor, no icterus, no clubbing, no cyanosis, no generalized lymphadenopathy, no pedal edema, and there is no signs of any liver cell failure. Pulse rate is 72 per minute. Blood pressure is 120 80 millimeter of mercury. Respiratory rate is 18 per minute. On examination of abdomen, an inspection, a mass of size 15 cross 10 centimeters seen in the right hypochondrium, extending to epigastrium medially and laterally 3 centimeters from the anterior axillary line. And the mass moves with respiration and skin is normal. On leg raising and head raising test, the mass becomes less prominent. The umbilicus is midline and inverted. All quadrants moves equally with respiration. A horizontal scar of about size 2 centimeters over hypogastrium present. No dilated veins, sinuses. Renal angle free. Hernial orifice is free. External genitalia normal. No supraclavicular force of illness. And palpation. No warmth, no tenderness. A mass of size 15 cross 10 centimeter, palpable in the right hypochondrium, extending into the epigastrium with upper border continuous with the costal margin, and lower border extends up to 5 centimeter above umbilicus. Medially, the mass crosses the midline and laterally about 3 centimeters from the anterior axillary line, with the surface smooth, well-defined margin, firm in consistency, and not pulsatile, and not able to insinuate finger between the mass and the costal margin. No guarding, no rigidity. Bilateral supraclavicular region, no palpable lymph nodes. And percussion, dull node present over the mass and percussion, which is continuous with the liver dullness, and the liver span is about 18 centimeter, and no shifting dullness or no free fluid in the abdomen. Auscultation, no bruit over the mass, normal bowel sound here. Per rectal examination, normal sphincter tone is present, no palpable growth or induration. Fecal staining seen on the examining finger. And other system examination, cardiovascular system, S1, S2 here, no murmur. Respiratory system, normal vesicular bed zone here, no added zone. Central nervous system, no focal neurological deficit seen. Summary. A 47-year-old female presenting with complaints of right hypochondrial mass for the past 1 year, with abdominal pain and fever for the past 1 month, with no other complaints of vomiting, altered bowel habits, loss of weight or appetite, no jaundice. On examination, a mass of size 15 × 10 cm over right hypochondrium extending into the epigastrium with well-defined margins. Upper border continues with the costal margin. Lower border extends up to 5 cm above umbilicus with smooth surface. Not able to insinuate finger between the mass and the costal margin. With firm inconsistency, not pulsatile. Dull note on percussion with no bruit. I would like to give differential diagnosis of. It's a case of hepatomegaly with probably due to a benign cause, maybe due to liver abscess or hydrated cyst and hepatic adenoma.
Malik, what is that horizontal scar you told? What is that horizontal scar?
Sir, the patient has undergone PS for 21 years of back.
Tubectomy.
Yes, sir.
Okay. And you have done both leg raising as well as the head raising test in your patient?
Yes, sir.
Why both?
So to differentiate between parietal and abdominal swellings.
No, I'm asking why both? You could have just done head raising
Yes.
test
Yes, sir.
because this was in the upper abdomen.
Yes.
And how did you measure? Where did you measure lever span in your patient?
So measured liver sample percussion starting from the 5th intercostal space and starting from 5th intercostal downwards below the costal margin, sir.
You know, whenever you have to tell about the lever span, you have to always tell
Okay.
in which area, which line it is you are telling about the lever span.
Okay, sir. Mid clavicular line, sir.
Okay. So in the mid clavicular line, if you think, can you just show that lump? Picture of that lump.
Yes, sir.
So does that lump comes in the mid clavicular line or not?
Yes, sir. Coming. It is in the mid clavicular line.
So how will you say that it is the lever span? If there's a lump in that area is there.
Yes, sir.
So if there's a lump like a gallbladder lump is there or a lump which is in that area is there,
Okay, sir.
then you have to change your site.
Yes, sir.
Okay, you can either go to the anterior axillary line
Okay, sir.
or you can go to the midline.
Okay, sir.
So can you tell what is the lever span in mid-clavicular line and in the anterior axillary line? How much is that? Normal lever span?
Normal liver span is 12 to 14 centimeters, sir.
Where?
In mid clavicular line, sir.
No, it is not. Isn't high? 12 to 15 centimeter? It's 9 to 11 centimeters
Okay. Okay,
in the
sir.
mid-clavicular line.
Okay, sir.
And
Okay, sir.
12 to 15 centimeter in the anterior axillary line.
Anterior axillary line. Okay, sir.
And one of the very important thing which you have not told in the summary, that this lump is moving with respiration. Can you go to the summary slide? I think that was one of the very important finding
Yes,
which you have not mentioned.
Yes, sir.
Have you mentioned that?
No, sir.
I do not see that
Yes, sir. I didn't.
you have mentioned that.
I
Yeah.
forgot. Sorry.
That is one of the very important.
Yes, sir. Very important. Yes, sir.
Yeah, very important sign. In the you have to tell in the examination about that.
Okay, sir.
So if you get a pulsatile, you said there is non-pulsatile.
Yes, sir.
So if you find a pulsatile lump in that area, how it will change your diagnosis?
Sir, maybe a swelling rising over the aortic artery. Sorry, it may be a hemangioma of liver, sir.
Very large hemangioma can give
Faint
right.
hemangioma. Yes, sir.
Yes. Any other pulsatile in the epigastric region?
Aortic artery aneurysm.
Abdominal aortic aneurysm?
Yes, sir.
Yes. Anything else? You know, what is the transmitted pulsation and the expansile pulsation if you get a lump in the epigastrium?
Sir, any swelling arising from the abdominal aorta, it will give a expansile pulsation, whereas the swelling above the arising from the organs above the abdominal aorta, it will get a transmitted pulsation, sir.
Like, can you give the example? What is that swelling which is in front of the aortic aorta, which will give the transmitted pulsation? The majority of the time the pseudopancreatic cyst.
Pseudocysta pancreas.
Pseudopancreatic cyst.
Yes, sir.
So how do you differentiate between expansile pulsation and the transmitted pulsation of a lump which is there in the epigastrium?
Place a finger, 2 fingers of a hand over the lump. If the pulsation is transmitted, it just lifts the finger. The pulsation just lifts the finger, whereas it is expansile, it lifts and separates the finger.
This is not a good test for the abdominal lumps. Okay, it is okay, like if it is in the periphery, is there in the extremity, there is a lump is there.
Okay, sir.
Like the radial artery aneurysm is there, you want to differentiate.
Okay, sir.
Okay, but not in the abdominal lump. In the abdominal lump, you have to differentiate between the transmitted and the expansile position. You have to do some other thing. What is that?
Yeah.
You have to make the patient either lateral
Or knee elbow.
or knee elbow position.
Yes, sir.
Okay.
Knee elbow.
Knee elbow is, you know, for the patient, it is not very comfortable.
Sir.
But if you make the patient lateral, if the pulsations they disappear, then it is the transmitted pulsation.
Yes, sir.
Okay, but if it is still there, it is the expansile pulsation.
Okay.
Okay.
One thing, probably every time Khanna sir and so many teachers have told you, go to previous slides.
Yes, sir.
All quadrants are moving equally with respiration.
Yes, sir.
So all move. They are moving. That is what you can say. The right lower quadrant don't move as much as the right upper quadrant moves. Right?
Yes, sir.
So take care. There
Yes,
are
you
certain
use the
fixed,
word proportionately.
proportionately.
Okay,
There
sir.
are fixed,
Proportionately, use the word that, not
Okay.
equally.
there are fixed proformas, wrong proformas fitted in all PG students, all majority of students. And I will like all of you students who are listening, please go back to the previous similar cases which have been discussed so that at least those can be revised while you answer. Right? And this is how everybody improves.
Okay, sir.
Carry on.
Malik, how will you differentiate whether it is a retroperitoneal lump or an intra-abdominal lump? If I say this is a retroperitoneal lump,
Yes, sir.
contradict me in that.
So this is a mass that moves with respiration, sir. Usually retroperitoneal mass.
Good. So that is the most important thing, that this is moving with respiration.
Yes, sir.
Okay. So that makes it the intra-abdominal lump rather than the retroperitoneal lump. Right.
Yes, sir.
Okay, you can go to your diagnosis now.
Yes, sir.
So you have made liver abscess, hydrated cyst, and hepatic adenoma. What about the cholecystitis?
Sir,
In cholecystitis, what type of the lump you usually get?
it's a soft globular mass, sir. It is soft, moves with respiration.
If a patient has acute cholecystitis,
Okay, sir.
what type of the lump is there? And what is that lump? In a case of acute cholecystitis, what is that lump?
With globular swelling, sir.
No. Which structures they make that lump? in acute cholecystitis.
Momentum.
Yes, momentum will come just like the appendicular lump.
Yes, sir.
Okay, so momentum will come, the bowel will come, the large bowel will come, so all
Okay.
those things. So
Transverse.
it will be
Yes.
never a very clear cut.
Okay, sir.
Okay, with a well-defined margin. It will be a vague type of the lump which will be there in that area.
Okay, sir.
Okay, but
Okay.
in this patient, it is a very clear cut lump.
Well defined margin. Yes, sir.
You are able to feel all the margins except the upper margin. You are able to
Yes.
feel all the margins.
Yes, sir.
Okay, so you are justified to keep a possibility of the liver lump. Why not a
Okay, sir.
colonic lump?
Sir, colonic lump, there will be history of altered bowel habits, sir.
Yeah, in your patient, there is no history of
Altered bowel habits.
change in the bowel habits
Yes,
is
sir.
there. So that
Yes,
is
sir.
one.
Yes, sir.
But if there is no change in the bowel habit is there, still I say it's a colonic lump. So which lump it can be?
The transverse colon, sir. Transverse colon.
Sorry?
Transverse colon, sir.
Yeah, transverse colon. Which lump it can be? The patient does not give history of any change in the bowel habit, but it is arising from the colon.
Yes, sir. Maybe.
A lump from the stomach is there, the patient doesn't have any hematemesis.
Sir. Just.
So which are those
Yes.
lumps?
Carcinoids.
Sorry?
Carcinoids.
You said something before that.
Cyst, sir. Gastrointestinal stromal.
Yes. So that is a possibility. Gastrointestinal stromal tumor.
Yes, sir.
Okay, so if the patient is not having any luminal things which are there in the stomach or in the colon,
okay, sir.
So you have to keep the possibility which is growing extramural.
Okay, sir.
It is coming out. Okay. So in the liver abscess, what is your possibility?
Maybe amoebic liver abscess, sir.
What is the commonest site of the amoebic liver abscess?
Right side, right lobe, sir.
Right lobe where?
Right posterior superior surface, sir.
So if the patient has got the amoebic liver abscess in that area, what findings you can get in a patient with the amoebic liver abscess?
The patient will be having an acute abscess. There will be pain, upper abdominal pain, sir.
Okay.
Findings, there is intercostal on percussion, intercostal tenderness will be there, sir. Tenderness on tender on palpation and intercostal tenderness will be there.
Where do you test for the tenderness?
Intercostal regions.
Intercostal tenderness.
Yes, sir.
Yes. One. What other findings can be there if there's a lump from the posterior or the right posterior one which is there? If you auscultate the chest, can you find
Yes,
anything?
sir. Yes, sir. Yes, sir. There will be decreased breath sound, sir. Right side, on the right side, sir.
What can you get?
Decreased breath sound, sir. Right side.
Because of?
Pushed up, elevated right hemidiaphragm, sir.
No, what happens in the case of like there's the amoebic abscess which is in contact with the diaphragm? What can happen?
There will be elevated right hemidiaphragm will be there, sir.
Yes. There will be elevated right hemidiaphragm. That you will see on the X-ray.
Yes, sir.
But what other findings can be there?
Can be ruptured into the liver.
Okay, before the rupture, can this patient have pleural effusion?
Yes, sir. Pleural effusion.
So what is the name of that pleural effusion?
Sympathetic effusion.
Sympathetic effusion. You know?
Yes.
So that finding you can get on the
X-rays.
chest examination.
Yes, sir.
Okay. What are the various types of liver abscess?
Amoebic liver abscess and pyogenic liver abscess.
One is amoebic,
The one is pyogenic, sir.
pyogenic, and what is pyemic abscess?
It's a pylophlebitis.
What is pyemic abscess?
Due to infection through portal veins.
Like a patient having the portal pyemia.
Yes, sir.
Okay. So you will get the multiple abscesses all over the liver.
Yes, sir. Yes, sir.
Okay. Pyogenic and the amoebic, they are the localized one. But the pyemic is a almost whole of the liver can be involved.
Okay, sir.
Now, why did you keep possibility of hydrated cyst, and how do you explain the fever in your patient if you are keeping a possibility of hydrated cyst? How do you explain the fever in a case of hydrated cyst?
Infection. There is an infection.
There may be infection inside the cyst. Yes.
Yes, sir. Infection, spontaneous infection or septicemia.
And then there may be associated cholangitis may be there in this
Yes.
patient.
Yes, sir. Cholangitis, sir.
What is the life cycle of the hydrated cyst?
Sir, definite hosts, it's caused by organism Echinococcus granulosus, sir, mostly. It is definite host dog, and when the dog intakes the cyst, and the cyst enters the dog intestine, and it goes into the adult worm, and it excretes the 500 about 500 to thousands of eggs in feces, and feces get fecally transmitted to sheep and human accidentally.
Is the human being a primary host or the secondary host?
It's intermediate accidental host. Sir.
This is accidental host. No? Yeah.
Yes, sir.
Accidental host.
Yes.
And what are the various layers of the hydrated cyst?
It is adventitious layer and laminated layer, laminated layer, and germinal layers.
So how many layers are there?
3 layers. Sir.
So which is the outermost?
Outermost is adventitious layers.
What is the name of that? Other name of that?
Pseudocystum.
Pericyst.
Pericyst, sir. Pericyst, yes.
Okay. And then?
Then laminated layer, also known as.
What is the other name of that?
Epicyst. Epicyst.
Ectocyst.
Ectocyst.
And
innermost layer is germinal layer. It is also known as endocyst.
What is malignant hydrated?
Malignant hydratis is caused by Echinococcus multilacularis, where it will mimic HCC, where there will be disseminated hydatidosis over the liver. It will involve both the lobe of liver, and it has worst prognosis.
Okay. And your third differential diagnosis is hepatic adenoma.
Yes.
Why hepatic adenoma?
So it's a benign swelling. It is a awareness from the liver. The middle-aged female, in a middle-aged female, you probably think of benign hepatic tumors, most probably hepatic adenoma.
So they give the differential diagnosis of localized lumps arising from the liver. 3 you have mentioned here.
Yes, sir.
What are the other differential diagnosis of localized lumps of the liver?
Hepatocellular carcinoma, sir.
Hepatocellular carcinoma, good.
Focal nodular hyperplasia, sir.
Focal nodular hyperplasia.
And hemangioma, sir.
Okay. What is radial slope?
Radial slope is an anatomical variation, extension of right lobe of liver along the anterior axillary below the carcinoma.
So can that present as a lump in that area?
Yes, sir.
Okay. Okay. Dr. Hitesh, you want to ask anything?
Yes. So what will you do now? How will you proceed?
Sir, I will do routine investigation and
No.
investigation. Sir,
See,
investigation.
whenever you are asked as a PG student,
Okay, sir.
what will you do? You have three differential diagnoses. What is your first aim?
The investigation to confirm the diagnosis, sir.
Yes, to reach to diagnosis. So
Yes,
what
sir.
will you do? Routine investigation, see, it's a vague word.
Okay,
Nobody in a OPD asks for routine investigation when a patient of such finding comes. Do you ask for routine investigation and then ask to go for other investigation?
No, sir.
Whatever you do, please tell me.
Okay, sir. I'll do investigation to confirm a diagnosis. That is, first to take ultrasound abdomen pelvis.
Okay.
In ultrasound abdomen pelvis, if there is to differentiate between these three, my three differential diagnoses, I'll come to your diagnosis and then see CT abdomen pelvis.
Always CCT?
Abdomen and pelvis.
Do you need it in liver abscess?
No, sir.
So
after confirming the diagnosis, I will plan the treatment, sir.
Nizam, you cannot, you can, sir said, you can know the organ of origin of the lump, one.
Yes, sir.
The extent of the lump, number two. Now, whether it is solid or cystic.
Cystic lesion. Okay.
No, it is, if it is cystic, what is the consistency inside? Is it clear fluid or anything? These are the things we can know. And how far is it extending? With by the ultrasound, can you differentiate between hydatid cyst or liver abscess or hepatic adenoma? You should say all these things. Then based on that, then you can go to the next one.
Yes,
Dr. Sandhu, sir, your United Faculty of, please, sir, you can. You're muted, sir.
Hello.
Yes,
Thank you, sir. Thank you.
You're asking
So
anything?
what?
Yes, sir, please.
Any other investigation you would like to do?
Sir, I would like to do MR. If it's I would like to do MRCP, sir, to assess any communication between the cystobiliary communication.
Are you expecting the cystobiliary communication in a patient?
No, sir.
Mm-hmm.
No, sir.
So if the cystobiliary communication is there, what the patient will have?
Jaundice.
Is it there in your patient?
No, sir.
So then why you want to do the MR? You know, on ultrasound, if you get a patient with a hydrated cyst, what are the various findings which can be there? You know any classification for the hydrated cyst?
Yes, sir. Garpis, Hassan's Garpis classification.
Okay, what is that?
It has 5 types. Hydrated cyst is classified according to ultrasound finding. Type 1. With clear, pure, with clear cystic fluid alone. Type 2 is with clear fluid with separated membrane separated. Type 3 is type 4 is both hetero and it is heteroechogenic, both hypo and hyperechogenic. Type 5 is calcified system.
So out of these 5 types, which one is most infective?
Type 2 and 3, sir.
Not the type 1?
The type 1 also. Type 1, 2 and 3.
Type 5 is calcified.
Calcified, that's it, yes, sir.
So that is why it is not infective, but otherwise, the earlier one, they are all infective. Jay.
Yes, sir.
Okay. So you have done the ultrasound and it shows it is the hydrated cyst. So what other investigation you are going to carry out?
Sir, I will look out for, I will do see contrast and CT abdomen pelvis, sir.
Why you want to do the CT?
Extent of the cyst we can see in CT, sir.
How many segments are there in the liver?
8 segments there in liver, sir.
Okay. What are those 8 segments? What are the classification? What is the name of that?
Coordinate segments, sir.
Okay. So how do you divide the right and the left surgical lobe and the anatomical lobe?
Anatomically, it is split by falciform ligament split, right lobe and left lobe. So, surgical lobe is an imaginary line drawn from the gallbladder fossa to the IVC.
So what lies in the that line? What is that line known as?
Cantley's line.
Cantley's line. Okay.
Yes, sir.
So what structure lies there?
Middle hepatic.
Middle hepatic vein.
Yes, sir.
Okay. And then how do you divide into the other segments? 8 segments. Which one is the number 1?
So number 1 is caudate lobe, sir. It's a paracaval in position. And with the gains, other 8 segments, it's left lateral segments as 2 and 3. Left medial segment is 4A and 4B. Right anterior segment 5 and 8. Right posterior segment is 6 and 7.
So how this segmentation is done? By which structure?
Hepatic veins, right and left hepatic veins.
No, the right hepatic and the left hepatic vein divides into the right and the left.
Yes, sir.
But subsegmentation, how it is done?
Branches of a hepatic vein.
No, that's where the portal vein branching.
Portal.
Okay.
Okay.
So main segments which are there is by the hepatic vein, but the sub which are there, they are by the portal vein.
Portal. Okay, sir.
So you have found there is a hydrated cyst which is occupying the segment 5 and 8.
Okay, sir.
On the CT scan.
Okay, sir.
You want to do any other investigation?
No, sir.
You are not interested in doing any other investigation for the treatment purpose?
Really?
You do not want to do any hydrated serology?
Yes, sir. ELISA, I do, sir.
Is it?
Direct hemogglutination.
Should it be done or not?
Yes, sir. Should be done.
Why? Why should be done? That shows the activity of the disease.
Okay.
So if the hydrated serology is positive, so one is for making the diagnosis,
Okay.
and second for the activity of the disease. Because if it is positive, then you have to be very careful when you're operating these patients that there is no spillage is there.
Okay, sir.
Otherwise, the patient would go into
Anaphylaxis.
anaphylaxis.
Yes, sir.
What other abnormalities you can get in the blood examination in a patient with hydrated cyst?
Sir, eosinophilia will
With
be
the
there,
simple
sir.
CBC,
Yes,
will
sir.
you get any abnormality?
Will be eosinophils will be better.
So there will be eosinophilia may be there. No?
Yes, sir.
Okay. So I have told you that this is a patient with a hydrated cyst which is occupying the segment 5 and 8. You have done the other test, serology is positive. How you are going to treat your patient?
Sir, I will plan the mode of treatment for the patient, sir. There is medical treatment, sir. Medical treatment and surgical treatment, sir.
Okay. So what is the purpose of doing the medical treatment?
Sir, it's, larvicidal, ovicidal.
And which medical treatment will you do?
It's an albendazole 10 mg per kilogram, but you wait for 10 days prior to the surgery and continued for 2 months post surgery.
Okay, so one is albendazole. Can you use any other drug?
Praziquantel can be given, sir.
Sorry? Praziquantel, okay.
Yes, sir.
Any other drug?
Mebendazole.
Sorry?
Mebendazole.
No, that you told the albendazole, isn't it?
Yes, sir.
Albendazole, praziquantel.
Yes, sir.
Any drug which has been used so frequently in COVID?
Ivermectin.
Ivermectin, yes. Okay, so these are the drugs which you can use. Okay, so you are given this drug for 2 weeks.
Yes, sir.
What is the plan now?
Sir, I will assess the I will do, since if the cyst is less than 10 centimeter or the cyst is since it is in the right lobe, we can go for PAR.
So what are the indications of PAR?
PAR is accessible cyst. Cyst with no biliary communication and
Yes.
single cyst.
Which Garbi you can do the PAR?
Sir, calcified cyst and Garbi 1, 2, 3 can do. We can do pairs. 4 and 5 we can't do pairs.
Okay. And what complications can occur when you are doing the PAR?
Anaphylaxis, rupture of the cystic fluid into the peritoneum can occur. Anaphylaxis.
Yes. Any other complication which can occur?
Infections. Sir.
If it is there is a communication is there with the biliary channels?
Yes, sir. Cyst can enter the rupture of the cystic fluid into the biliary tract can occur.
It can lead to cholangitis and sometimes even the sclerosing cholangitis.
Yes, sir.
Okay. And if the patient develops a sclerosing cholangitis, now it is a very difficult disease to treat.
Okay, sir.
Okay. So in this patient, you are given the albendazole and you are planning for the surgical treatment. So what are the various options in the surgical treatment?
Sir, with laparotomy, with open.
Only the laparotomy or something else can also be done for the surgical treatment.
Sir, with the open aspiration and evacuation of cyst with the injection of cholecystitis agent.
One is the laparotomy.
Okay, sir.
Anything else can be done? Can you tackle this cyst laparoscopically?
Yes, sir. Laparoscopically we can.
So both are the options, no?
Yes, yes, sir.
Okay, if you are having expertise for that, both are the options which are there.
Okay, sir.
So when you are doing either of the procedures, what precaution you are going to take at the time of and what you are going to do?
Sir,
What are the surgical?
Sir, we'll pack the peritoneal cavity with pads soaked in cholecystitis agent, sir, 20% hypertonic salines.
Okay.
And then injection of cholecystitis agent into the cyst and wait for 20 minutes for the cholecystitis agent to act. Then open.
So which cholecystitis you will inject in the cavity?
20% hypertonic salines.
Hypertonic. Why not the povidone iodine?
It has a risk of cholangitis.
Yes, it can cause cholangitis. Any other disadvantage of you inject the povidone iodine? Initially it was, okay, we used to put that. Okay, it will color the fluid there. So
Okay.
if there's any biliary communication is there, you will not be able to appreciate.
Yes, sir.
If it is colored that fluid.
Yes, sir.
Okay, so that is why it is not injected in the cavity now.
Okay, sir.
So what are the various options from the surgical point of view?
Sir,
What are the things you can do?
open aspiration evacuation of cyst with pericystectomy can be done, sir. If not, partial pericystectomy with marsupialization can be done, sir.
You know, the commonest operation which is done is
open aspiration and evacuation of cyst with partial pericyst.
now what is that called as? Enucleation of the cyst.
Enucleation. Yes.
Okay, but that is not a very good option. The option is that you remove it with the pericyst.
Okay, sir.
Because otherwise there will be always a hollow cavity which will be there, and the patient will be always bothered that you have not treated that patient. So that is the best option. But if it is in the right lobe is there, that is a difficult option. If it is in the left lobe is there, it is good.
Yes,
but in the right lobe, it is a difficult option.
Okay.
What is decapitation?
Removing the cyst along with the hepatic.
Decapitation means cutting the head.
Remove
You are cutting the head of that patient. So you are cutting the head of the, which is the bulging area which is there.
Okay.
So what are the organs where you can do the decapitation apart from the liver?
Or de-roofing?
Pancreatic.
Okay, but if the kidney is there or the spleen is there, you can do that decapitation or de-roofing.
Yes, sir.
Okay. What you do if it is a lung hydrated is there? Have you ever seen a case being operated for the lung hydrated?
No, sir. Medically treated.
Can the anesthetist be helpful to you in treatment for the lung hydrated?
Specialized intubation.
You ask your anesthetist to give the full blow, and it just pops out like that. Okay.
Okay.
So that is in the case of lung hydrated. Okay. So you have done the patient the enucleation, and now you find that there is a bile staining which is there.
Okay.
What are you going to do?
Sir, I'll place a ligate the communication, or I'll keep a T-tube drain over the bile ducts.
So if you are able to ligate that, okay, you will always check for the bile duct of that patient.
Yes, sir.
Because there may be the ruptured cysts which are there in the bile duct.
Okay.
Okay, and if there are cysts in the bile duct are there, you have to explore the bile duct, remove that, put a T-tube in there. Okay. Now you find that the bile duct is normal, but there is some ooze which is there which you are not able to find out. Sometimes it is very difficult. If there is a big cavity is there, you are not able to find out that from where this bile is coming.
Okay.
What you will do?
Well, after evacuating the cyst, we'll place a white pad over the cavity and squeeze the gallbladder. If it is staining for bile, we'll confirm it is biliary communication.
You know, sometimes it's very difficult. You are not able to find out from where this small drop of bile which is coming.
Okay. Intraoperative cholangiogram.
Okay, that is one possibility. Yes. So either you can put the omentum in that, what is the omentopexy which is there?
Yes,
and probably that omentum will probably
block
cover that area.
Okay.
Or if you think that it is a little more, and if you are able to do some bypass,
yes, sir.
So you can do like a cystojejunal bypass can be done. You can drain that cyst into the roux loop, and that will also help in carrying out this.
Okay.
Okay. And all these patients in the post-operative period has to be kept on the albendazole.
Yes, sir.
Okay. Dr. Sandhu, you want to ask anything?
Thank you, sir. Fine, fine.
Dr. Hitesh, can we call it a close?
Yes, yes, sir.
It's already 1 hour is there.
Two more cases are
Yes.
pending.
Yeah,
Yes,
two
sir.
more cases are there. Yeah.
Kanagwal, sir?
Dr.
Sir, we show the
Kanagwal.
pictures.
Yes, sir. I will show. Sir, this is picture of
Just show the
PCT
picture. Yeah, just show the
Yes,
picture.
yes.
Yeah.
This is what, yes.
PCT, left lobe of liver involving of size
Right.
19 plus 20 centimeter size, sir.
Okay.
Did a laparotomy and aspiration with partial persistent woman to pexivitates.
Right.
Thank you, sir.
Okay.
Congratulations. Well done.
Thank you, sir.
Thank you. You can close.
Thank
Yes,
you,
sir.
Unshare so the next person can.
Monisha, are you with us? Dr. Monisha?
Yes, sir.
Okay, you can share your PowerPoint, introduce yourself.
Yes, sir. One second, sir.
Kanagwal, sir, is our Napoleon. He was sleeping on horse. Sir is doing everything from car.
No,
Or
sir.
OT or what.
Give privacy, sir. Nobody disturbs when you're sitting in the car, sir. That is when you are out, somebody calls you, you cannot tell you are in a class. So this is the right place for me, sir.
But hats off to you for so many classes. Hats off, sir.
Sir, everybody's effort, sir. It is not my effort, sir.
No, but sir, you are always there, not on time. Khanna sir and Srinivasan sir are very much regular, but rest people are not as regular as you.
No,
three
sir.
people are.
Someone or other bridges, no, sir. Sir is coming or someone is coming. So everybody also has other commitments coming up, no, sir, nowadays.
Yes, sir. But hats off, really, it's a great gesture.
Credits to everybody, sir. It's
And everybody is learning, including ourselves.
Yes, sir. Yes, sir. I think, sir, can we move to the next case, sir? Arvind sir is still held up in an emergency, it seems, sir. So he will come little late only. So now we have Dr. Monisha, kindly contributed by Dr. Raj Ashok, sir, head of the unit, and then Dr. Professor Sumati Madam from Mohan Kumar Mangala Medical College. Monisha, please, sir, this will be for half an hour. So this will be one short case, and another short case is from Monica. Then we'll be going for that case by about 9:30, sir. So plan accordingly, sir, discussion. Monisha,
Yes.
make it full screen and start your presentation, ma.
Yes, sir. Good evening, everyone. Sir, is my presentation visible, sir?
You are good to go, ma.
Yes, sir. Thank you,
Like
sir.
a short case.
Yes, sir. Thank you, sir.
Proud.
Good evening, everyone. I'm Dr. Monisha, doing my second year MS postgraduate in general surgery from GMKMC Salem. Before starting my presentation, I'd like to thank my HOD, Professor Dr. Vijay Kumar, sir, and Chief Dr. Professor Dr. Rajashok, sir, for guiding me for this presentation. I'll proceed with the presentation. A 48-year male presented with chief complaints of
Monisha,
ulcer.
would you make it full screen?
Sorry, sir.
Full screen and slides. Lord, your slides are not moving.
No, sir. It's one second, sir.
Manisha, if you're not able to do, tap on the second slide.
Okay, sir. It's moving, sir.
Down you see the 70% பாக்குறலமா அது பக்கத்துல ஒரு பாரு கப் மாதிரி இருக்கும் பாரு.
One second, sir.
Take your cursor there. Down.
75% பக்கத்துல பாரு.
பக்கத்துல பாரு. This one.
Right lower corner.
Yes, sir. Yes, sir.
Here that there's a cup, isn't it?
Yes, sir.
Yes, click that.
Yes, sir.
You clicked it, but it's rolling. You don't think you go and click it, slide number 2.
Nice, sir. Now is it changing, sir?
Yeah, just changing, but not making full screen.
Yes.
Yeah, you present, ma.
Now, sir?
No, it's not coming. You present.
Okay, sir.
You present like that, present, isn't it?
Sorry, sir. Sorry for the inconvenience, sir.
No problem. Somebody was shouting. Somebody
Yes,
was Somebody was speaking in the phone. Yes, sir. Sandhu sir and Karnar sir, please. You start presenting my.
I'll start, sir. Yes, sir. A 48-year male presented with chief complaints of ulcer in the inner aspect of the left cheek for past 6 months, with complaints of swelling and pain in the left side of face for past 3 months, and history of difficulty in opening the mouth for past 3 months. The patient was apparently normal 6 months back, after which he noticed a small ulcer in the inner aspect of the cheek, which he noticed while chewing, which gradually increased in size, that he is now able to feel the swelling on his face for past 3 months. And that swelling is associated with pain, which is intermittent pricking type and not radiating with no aggravating or relieving factor. And there's also a history of difficulty in opening the mouth for past 3 months with increase in severity for past 1 month. And he also gives a history of bleeding from the swelling 10 days back, just a single episode. And he also gives a history of burning sensation in the left cheek inner aspect for the past 2 years whenever he's chewing tobacco. And there's no history of foul smelling discharge from the ulcer or fetor oris, and there's no history of difficulty in chewing, swallowing, speech, or excessive salivation. There's no history of swelling elsewhere in the body, and there's no history of loss of weight or loss of appetite. Past history, it has no comorbidities, known comorbidities, and there's no history of previous surgeries and no history of prolonged medications. A personal history, he's a known alcoholic for past 25 years and has history of tobacco chewing with betel leaf chewing with areca nut, slackline paste for past 25 years, and there's no history of smoking. On examination of the patient is moderately built and nourished, afebrile, comfortable at rest, not tachypneic, no paler icterus or pedal edema, and there's no significant generalized lymphadenopathy, and his vitals were found to be stable. On systemic examination, CV is S1, S2 present, there's no murmur. RS is bilateral R entries are present with no added sounds. Per abdomen is soft, no distension, no tenderness, and bowel sounds present. CNS examination, there's no focal neurological deficit. On local examination, this is the clinical picture of the patient showing ill-defined swelling of 4x4 centimeter in left cheek, just anterior to the ramus of the mandible, and skin over the swelling appears normal. There's no sinus, there's no dilated veins, there's no ulcers over the skin of swelling. On examination of the oral cavity, the lips were found to be hyperpigmentation found over the lips, and there is tobacco staining present over the teeth, and there is an ulceroproliferative lesion of about 4x3 centimeter present in the mucosal surface of the left cheek, extending about 1 centimeter from the and 2 centimeter from the anterior commissure. The posterior border of the swelling is not visible. Upper extent, it extends about 1 centimeter from the upper alveolar ridge, and inferior margin of the ulceroproliferative lesion is not visible. And there is a on both the cheeks and all over the mucosal surface, there is a white mesh-like lesions, probably submucosal fibrosis. And on the anterior surface of the tongue, here it shows a white patchy lesion, probably a leukoplakia. On this is the detailed picture showing the ulceroproliferative lesion in the buccal mucosa. And this picture shows there is limitation in opening of the oral cavity, which is restricted to 2 fingers of the patient. And tongue movements were found to be normal. There is no restriction in the tongue movement. On palpation of the left cheek, the swelling is not warm, not tender. The 5x4 centimeter hard swelling present in the left cheek just anterior to the ramus of the mandible. Skin over the mandible is indurated and not pinchable. On examination of the oral cavity by this ulceroproliferative lesion is thick, hard, measuring 5 centimeter in length and 3 centimeter in height and 2 centimeter thickness. Extend craniocaudally, it extends about 1 centimeter below the superior alveolar ridge and approximately 0.5 centimeter above the inferior alveolar ridge. Anterior-posteriorly, it extends 2 centimeter from the left angle of mouth, extending into the retromolar tribone, and the posterior margin of the swelling is not palpable and it doesn't bleed on touch. On examination of the neck, inspection, the neck appears to be normal. On palpation, few palpable nodes are present in the submandibular region, which measures less than 1 centimeter, and one single mobile hard node of 1 cross 1 centimeter present in the left upper cervical region. From my clinical examination, I come to a conclusion that it is an ulceroproliferative lesion in the buccal mucosa, probably carcinoma of buccal mucosa, and a clinical staging of T4N1M0. Next, then I'll proceed with edge
Wait.
biopsy. Sir?
Wait. Can I talk? Hello?
Yes, sir.
My name is Lakshan Prasad.
Wait.
Kanagwela, good evening.
Sir,
Good
good
evening,
evening, sir. Good evening, sir. Please go ahead, sir.
Okay. Now, why do you say it is a carcinoma?
Sir, it is in hearts. It started as a small swelling and increased in size, and it is a heart swelling.
No. You are not starting properly, man. So,
Sorry, sir.
ulcers in the mouth are supposed significant. Can you tell according duration? Any duration of more than a particular period is supposed to be important. So, what is the
Yes, sir.
duration of this?
The duration of the present complaint is for past 6 months,
So, is it significant?
with a rapid increase in size over the past 3 months, sir.
You answer my question.
Yes,
Is an
sir.
ulcer in the mouth, oral cavity of 6 months duration, persisting ulcer in the oral cavity for more than 6 months, is it significant?
No, sir.
Not significant.
Sir, not coming to significant ulcer, sir. Like persistent ulcer in the oral cavity is significant. That is not healing spontaneously is significant, sir.
Persisting for more than 3 weeks
Yes, sir.
should be considered as malignant unless put otherwise.
Yes, sir.
That's very important.
Yes, sir.
Point is, do you have any other diagnosis in mind other than carcinoma?
Probably minor salivary gland tumor, sir.
How common is it?
It's very rare, sir.
Then why do you want to talk about that? Yes.
Yes, sir. No other diagnosis, sir. DD, sir.
No diagnosis. Okay, good. Now, has he got any predisposing factors?
Yes, sir.
What is that?
From the examination, there is a white patches all over the neck.
Pre-malignant lesions are different from.
Okay.
predisposing
He's a
factors.
known case of, he has history of tobacco chewing, sir, for past 25 years. And
What is the smoke index or whatever index, tobacco index for this patient?
Sir, is tobacco chewing, sir? There's no history of smoking, sir.
Okay. So what does tobacco contain to cause malignancy?
Sir, the alkaloids,
What does tobacco contain, which is supposed to be significant, which can cause which can cause oral cancer? It's very basic point you should remember.
yes, sir.
Which is carcinogenic. Do you know of nicotine?
Yes, sir.
Yes. So is it the only factor for this case?
No, sir. There's history of beetle chewing with areca nut chewing and lime, sir. And slaked lime, sir.
Okay, good. Yes.
For past 25 years, sir.
Yes. So what about this pre-malignant condition in this patient?
Pre-malignant condition he has, sir.
Has he got any pre-malignant conditions?
Yes, sir.
Like what?
He has a submucosal fibrosis, sir.
Okay.
Over the buccal mucosa, and there is a leukoplakia over the tongue, sir.
Okay. So which leukoplakia are supposed to be more problematic? Are all leukoplakia pre-malignant or only certain leukoplakia are malignant?
Whereas homogeneous leukoplekia is less pre-malignant, sir.
Leukoplekia is pre-malignant.
Sorry, sir.
Homogeneous leukoplekia. What did you say?
It has less malignant potential when compared to the others, sir. That
What other types of leukoplekia?
nodular leukoplekia and speckled leukoplekia, sir.
So speckled is more important.
Yes, sir. Speckled leukoplekia is more malignant, sir.
What is the incidence of malignancy in a leukoplekia?
Sir, around 10 to 50%, sir.
10 to
50%. It depends on the leukoplekia, sir. Where speckled leukoplekia has 80% chance of turning into malignancy.
No. It's not 10 to 50%. I don't know where you got this information. It's only 10 to 20%.
Okay, sir.
What other pre-malignant?
Sir?
Other than a speckled leukoplekia, what?
Erythroplakia, sir.
Other types of leukoplekia. Leukoplekia in a non-smoker is more dangerous.
Yes, sir.
Leukoplekia in a female is more dangerous.
Varicose leukoplekia, sir.
Leukoplekia in a non-smoker, leukoplekia in a young female, leukoplekia associated erythroleukoplekia, leukoplekia at multiple sites, and leukoplekia in the further mouth. So remember, speckled leukoplekia, most important, leukoplekia in a young female, leukoplekia in a non-smoker, leukoplekia associated erythroplakia, unusual sites, and further mouth. These are more problematic than other. So what is the definition of leukoplekia? WT definition as on now.
Sir,
what is leukoplekia?
Leukoplekia is a white patchy lesion found, which cannot be.
See, any definition must be told as is given in the books. You cannot have, when I say definition, it should be reproduced what it says. Other things, there is always a margin of your own language. Some of these definitions you have to be reproduced as is given in the books.
Yes, sir.
There is a definite definition for leukoplekia and erythroplakia.
Yes, sir.
Can you tell me, please? You are trying to tell something. Come on.
What was the performance score of your patient? What was the performance score of a patient?
Sir, it's breaking, sir. Hello.
What was the
performance scoring
score of a patient? What was the performance score? What was the performance score? You have not mentioned it.
Performance scoring.
You know any performance scores? What are the scores?
See, ECOG scoring and Karnofsky.
Have you listened about Karnofsky or ECO scoring?
Is it audible?
No, sir. It's breaking, sir.
Have you heard about Karnofsky score or ECOG score?
Performance. ECOG score, sir, but.
What is ECOG?
I've heard it, but I don't know in detail, sir. I have to say, sir.
Mention the
What is the full form of ECOG?
Sir, Sandhu sir is asking what is the performance status of the patient?
Yes.
Is it ECOG or Karna, which you are told? You are not mentioned.
Yes, sir. I didn't check the performance score, sir.
Okay, right.
You have not told anything. You have not mentioned any. Yes. Now, how will you further work up with this patient?
Sir, I'll take a H biopsy from the ulcer in the oral cavity and take a.
Am I audible?
Yes, sir.
Sir, your voice is little bit breaking, sir.
Breaking, sir. Sandhu sir.
Hello.
You please ask, sir. Sandhu sir, your question, please.
So how will you further work up with this patient? How are you going to further work up?
Sir, I'll proceed with biopsy from the oral cavity ulcer, sir. And I'll take FNAC from the neck node. And then I'll do a CT neck with base of skull and the local part, and MRI neck and local part. From this, I'll come to a conclusion of my diagnosis, sir.
Which will you do first? See, when you put a USG neck,
Sir?
you put FNAC of the neck node, then you'll do an ultrasound of the neck. Which will you do first?
Ultrasound of the neck, sir.
Then why don't you put that as the first one?
Sorry, sir.
So you do an ultrasound, then right?
Yes, sir.
You can do an ultrasound. Now, for what are the characteristics of a secondary node in an ultrasonogram?
Characteristics of the node in.
Yeah, how do you say that the
ultrasound.
node is secondary on
Yes,
doing
sir.
an ultrasonogram?
Sir, there's a loss of hilum in the node, sir. In the
Shape. First, start with the shape.
shape, sir.
From bean shape, it becomes round.
Sir,
From bean shape, reniform shape, it
Yes, sir.
becomes round.
Round in shape, sir.
Then loss of fatty hilum. Yes, number
Loss of fatty hilum.
Number 3. So this is common for every neck. Any node secondaries.
A hard node.
Hard node, right? Okay.
A node infiltrating into the surrounding structures, sir. Fix it to the surrounding structures.
This is clinical. You're done your clinical examination. You're done with your clinical examination. You said it is a node.
Yes,
Fix a node. Yes. What will be the size? What will be the type of cells? Is it taller or wider? Which is more important, taller or wider? We're going to read. We should read it, okay?
Okay, Monisha. Am I audible?
Yes, sir.
What kind of biopsy you take in this lesion, particular lesion?
I'll take an edge biopsy from the ulcer, sir.
See, keep it in your mind. The lesion is present in the, what I say, is it involving the retromolar trigone or not?
Yes, sir.
Is it involving the retromolar trigone? Yes, am I right?
Yes, sir.
So, edge biopsy is a general terminology. Can you put your hands inside the oral cavity and take an edge biopsy?
No, sir.
Then how will you take an edge biopsy?
With the help of with the help of laryngoscope, sir.
See, the point is, it is very well visible.
The anterior margin from I can take it, sir.
See, my point is, can you use any instrument to take a biopsy for easy accessibility? See, in edge wedge biopsy, you cut the edge in a V shape and remove it. Whereas here, he has got a. Is he able to open his mouth freely?
No, sir. There is a restriction, sir.
There is a trismus present.
Yes, sir.
You cannot put your hand inside and take a biopsy. How will you take a biopsy? It's a common sense question. Can you use any instrument to take a biopsy? Can you do a punch biopsy?
Yes, sir.
Can you do a punch biopsy?
Yes, sir.
Where else you can do a punch biopsy?
From here, sir. From CA breast, sir.
CA breast. Why do you do a punch biopsy in a CA breast?
Sorry, sir. A punch biopsy we do in all skin malignancies, sir.
See, keep it in your mind, very logical. And punch biopsy in posterior 1/3 of the tongue where you cannot access.
Yes, sir.
You can take a punch biopsy.
Yes, sir.
If there are any lesions in the soft palate, we can take punch biopsy from the cervix, CA cervix. We can
Yes,
take
sir.
punch biopsy from the CA rectum. Does it make sense?
Yes, sir. Any deep-seated, not easily
Yes,
accessible, we can go for a punch biopsy, sir.
narrow space, we can use a punch biopsy. Yes,
Yes, sir.
that is what I want to see. You said there is a trismus and he cannot open his mouth adequately to put your fingers inside. So you can take a biopsy with the help of a punch.
Yes, sir.
Yes.
Yes, sir.
What will you find? What could be the HPE finding?
Sir, squamous epithelial cells with keratin pearls, sir, possibly because most common malignancy in oral cavities, squamous cell carcinoma. I'll be expecting squamous epithelial cells with the keratin pearls, sir.
How much significant is the keratin pearls?
Based on the keratin pearls, we can classify the differentiation, sir, like well
Yes.
differentiated,
Good.
moderately
Good.
differentiated, or poorly differentiated, sir.
What is that classification called?
Sir,
What is it classification called?
uh,
Some great people have discovered it. At least try to remember. Borders classification.
yes, sir.
Okay. So Lakshman sir, any questions? Or Sandhu sir?
Okay, can I go ahead?
Yes,
Please,
sir.
Please, sir, please.
Hello. When do you recommend CT? When do you recommend? What are the indications where you recommend CT for any case of carcinoma cheek?
So when I expect involvement of the mandible, when I expect involvement of the bony involvements. Sir?
How do you know clinically mandible is involved?
So when the swelling is fixed to the mandible, extending into the mandible. And
Clinically, what changes in the mandible or palpation
of
to know
tooth.
the clinically?
There might be
What?
loosening
Loosening
of
of
tooth.
the tooth.
And there's a fracture in unstable mandible, sir. There may be
Not necessarily fracture, is not irregularity,
irregularity, sir.
thickening.
Thickening of the mandible, sir.
How do you know mandible is thickened?
I'll just walk my fingers through the mandible, sir.
Person. Mandible thickness varies person to person.
Yes, sir.
So which you think is thickened mandible? It may be normal for that particular person.
I'll compare with the opposite mandible, sir.
Exactly. I'm happy you got the point. So always
Yes,
compare the opposite half and see whether the mandible is same equally thickened or there is any thickening in this case.
Yes, sir.
So you can also confirm by OPG.
Yes, sir.
Have you heard of PUF CT? PUFF PUF CT?
No, sir.
PUFF PUF CT.
No, sir.
So where you blow the mouth and make it cheeks get away from the floor of the mouth and see for involvement of the floor of the mouth. Once you make a puff and then you push some air, the cheeks will come off the floor of the mouth. Then you can see what the floor of the mouth is involved. Okay, you said like already indications are involvement of the mandible. Other indications are
Involvement of, when I suspect involvement of the pterygoid plates, when I suspect involvement of the base of skull.
pterygoid region. Okay, good.
Pterygoid region.
Presence of trismus.
Yes, sir.
Presence of trismus.
Indicates there might be involvement of the pterygoid muscles, sir.
Good. Trismus. Then any unknown secondary, if there is no secondary in the neck, clinically no palpable secondary also, you do a CT.
We can see CT, sir.
You do a CT.
Yes, sir.
Why do you want to do a chest X-ray for this case?
Chest X-ray, one indication is that these kind of patients are more prone for aspiration of bronchopneumonia, sir. So I can look in for any lesions.
Good. Maybe acceptable answer. Yes.
And for secondaries in the chest region, sir. Basic investigation.
Why do you want to recommend the indirect laryngoscopy?
Yes, sir. To indirect laryngoscopy, I can see the posterior extent into the post, if it's involving whether there is any other lesion in the posterior third of the tongue or extending into the pharynx, I can see, sir.
Have you heard of Field cancerization.
Sir?
Field cancerization.
Cancerization.
Have you heard of the word
No, sir.
field cancerization?
That is what you are substantiating.
Why you should do an ID. The sir is asking, pulling out the answer from you. Field, you get there and there you get bunches of crops, isn't it? So you get field cancerization, oral cavity is more common. So
Okay,
you
sir.
should look for the field cancerization to do an ideal.
Yes, sir.
This patient is a chronic smoker for the last 35 years.
Yes, sir.
There is a possibility that may develop synchronous cancer in any part in the aerodigestive tract.
Yes, sir.
So all the parts which are exposed to that may are
Small.
liable for development of cancer. That's what is
Cancer.
called the field cancerization.
Yes, sir.
So why do you want to do MRI?
For the soft tissue extent of the tumor, sir.
What exactly in the soft tissue?
The muscle involvement, what are they extending into the other muscles, extent of the sir?
What muscle?
The buccinator, sir.
Okay. So what that you
And-
want?
Sure, but-
Need a MRI?
Yeah, no, sir. But MRI can get a clear picture of how extent is the tumor, sir.
Okay.
Primary
So-
tumor extension, I can be more clear, sir.
What is the cause of swelling on the cheek?
Sir?
You said some swelling on the left side of the cheek.
Yes, sir.
Why is developing the swelling on the cheek?
As the tumor started in probably my view is that the tumor started infiltrating into the skin, sir.
Into the skin. So you
Yes,
left
sir.
alone, what will happen to this patient?
He'll develop a orocutaneous fistula, sir.
Wonderful. Okay, now I think we'll go ahead because you're already given data and time for 9:30 p.m. by the conveyor. So what will you do for this patient?
So first,
what-
after I have to
Apart from-
confirm my diagnosis, sir, and
Good.
then after confirming the diagnosis, I have to proceed with the staging of the malignancy, sir. Only after
Okay.
the staging, I can get a clear view of how I proceed, sir. Whether I'll proceed with the surgery, or I can proceed with the neoadjuvant chemotherapy or then surgery, or if my patient might go in for a palliative radiotherapy. It all depends on my staging, sir, after the investigation.
Due
No,
to
you
lack
said
of,
So
due
you are
to
already staged
lack
now.
of time, I'll give you this your confirmed is squamous cell carcinoma. The
Yes,
depth
sir.
of invasion is C3.
Yes,
Okay.
sir.
With neck nodes of N2 staging, what will be your plan of management? Because we have to finish this case and go to the next case. So
Mm,
with
Okay, good. Go ahead.
Good.
I
What
first
is-
go with the neoadjuvant N2, sir. N2, I'll proceed with left side commander's procedure, sir. I'll proceed with the wide excision of the tumor with marginal mandibulectomy and left-sided modified radical neck dissection, sir.
N2. Sir, is it acceptable, sir?
No, wide excision, do you think you can save the cheek?
No, sir.
Then what are how are you going to
I'll-
how,
I have to. I'll do a flap cover for the defect, sir.
what do you mean, flap?
You have lot of coverage to be done. You have to cover, replace this skin, replace the subcutaneous tissue, the mucous
sir.
membrane. If it is the bone, you have to put an osseous flap.
Yes,
These
sir.
are the 4 things in it. So what you have done a marginal mandibulectomy, you said since it's involved, you have done a wide local excision. Now,
Yes,
what is
sir.
the appropriate flap you would like to put for this patient?
I'll go for a forehead flap, sir, or I'll go for pectoralis major myocutaneous flap, sir.
You follow, sir. Sandhu, sir, your views. Dr. Sandhu, sir, you're muted, sir. What is your views? What is the line of management you would like to know? I think his voice is breaking.
I think third case, sir.
Pardon, sir? His voice is breaking. Sir, Lakshman, sir, Ningle Muding, sir.
Monisha,
Yes, sir.
would you Please go one slide back.
Yes, sir.
It is carcinoma, buccal mucosa. What is your treatment, as you said? T4N1M0.
Yes, sir.
Next slide. Next slide. Next slide. Yes. For this patient, what is your treatment?
For this patient, I'll proceed with if my diagnosis after investigation is confirmed as T4N1 lesion, I'll proceed with surgical excision of the tumor along with marginal mandibulectomy with modified radical neck dissection on the left side, followed by adjuvant chemoradiotherapy, sir.
Keep it in your mind. This patient has got a trismus, yes or no?
Yes, sir.
Then how the patient is going to get intubated?
That's also true, sir.
How can the patient
I'll proceed with a chemotherapy, sir, and wait for the response. If
see, the role of chemotherapy in head and neck cancer is secondary. Either you go for surgery or radiotherapy.
Yes, sir.
Okay, so you don't say saying chemotherapy is not correct.
Okay,
either
sir.
you go for surgery or go for radiotherapy.
Yes, sir.
What is the disadvantage associated with radiotherapy in this patient?
In this patient,
so if at all you proceed with radiotherapy, what are all the side effects?
There are many side effects, sir. In the mandible, it might cause radionecrosis or osteoradionecrosis of the mandible, which might be problematic, sir. Then local in the skin, it can cause the dermatitis. Xerostomia, tongue dryness.
Why are the osteoarachnosis more common in the mandible compared to maxilla? Why maxilla it is not common? Why always we talk about mandible only for a Warren? Mandible is more dense and less vascular. Maxilla is less dense and more vascular. What precaution you take before you do a radiotherapy?
The local part, I'll go for excision of the teeth, sir.
Make the patient adentalus.
Adental, yes, sir.
Correct words, not
Adental.
excision.
Sorry, sir. I'll go for tooth extraction, adental.
Why does the patient develop xerostomia?
Radiation induced, sir. Loss of glands, sir. The minor salivary glands will get damaged and the patient might develop dryness, sir.
Okay. Srinivas, sir, can we stop, sir? Srinivasan?
Sir, you are muted, sir.
Sir, any other?
Srinivasan, sir, I think, Monisha, do you have any questions? Any doubt to be clarified with the faculty?
No, sir.
Okay. Thank you, Dr. Monisha. Thank you, faculty. Now we move on to the next case. Monica, are you with us?
Good evening, sir. Yes, sir.
You please start your PowerPoint, ma.
Yes, sir.
Monisha.
Are you able to do, Kana?
Monica, you are muted.
Make it full screen, Monica.
Yes,
we are able to see your slides.
Yes, sir.
Press F5.
Sir, is my slide visible, sir?
Yes, ma. Yes, ma. Good to go.
Yes,
Go
sir.
ahead. Kana. All the best.
Good evening, sir. I'm Monica Sarojini, surgical postgraduate from Tirunelveli Medical College, sir, under the guidance of Dr. Alex Arthur Edwards, sir. Sir, this is Mr. X, a 76 years old male patient from Coimbatore. He is a farmer by occupation. He presented in the OPD with complaints of itching over the ulcer in the left side of the face for a duration of 3 years. History of pressing illness. The patient was apparently normal 3 years back, after which he developed an ulcer in the left side of face for 3 years. Initially, it was small in size. It then progressed to attain the present size. There is history of itching, which was aggravated for the past 3 months. And there is also a history of prolonged exposure to the sun. There is no history of any discharge, any pain, bleeding on touch, or trauma.
Your slides are not moving.
Not moving.
Sir.
You make it full screen, ma.
You can full screen, or you can just click the next slide whenever you are speaking.
Yes, sir.
Slide show if you can do.
66% on the bottom.
Yes, sir.
Next to that, something like a cup. Can you click that?
Yes, sir.
Yes.
Sir, it's now visible, sir.
It is moving, but not full screen yet.
Can I press that screen type again, ma?
Yes, sir.
Are you clicking that right?
Yes, yes, sir. Yes, sir.
Okay, Kana, don't worry. You touch on the
Yes, sir.
slides as Hitesh said and keep going.
Yes, sir. There is no history of any discharge, any history of pain, any history of trauma. There is no history of any bleeding on touch. There is no history of exposure to chemicals or radiation exposure. There is no history of any scar. There is no history of any loss of weight, loss of appetite, any chest pain or hemoptysis, no history of jaundice or no history of abdominal distension. Past history, there is no history of any similar complaints in the past. Patient is in...
Slides are not moving.
Sorry,
You
sir.
have to click. You have to click every time.
Yes, sir.
Okay, now. Yes.
Yes, sir. Past history, patient is a known diabetic and hypertensive for 5 years on regular treatment. There is no history of any tuberculosis, bronchial asthma, or any coronary artery disease. Personal history, patient is a non-alcoholic and non-smoker. He's a farmer by occupation. Family history, there is no history of any similar complaints in the family members, and there is no history of any treatment regarding the current illness. General examination, patient is conscious oriented, afebrile, he's thin built and nourished, vitals are stable, there is no pallor, ictus or any lymphadenopathy. Local examination, it is an ulcer, single ulcer of size 2 × 2 centimeter near the inner canthus of the left eye. It extends superiorly 0.5 centimeter below the supraorbital ridge, and inferiorly it's just above the medial canthus of the left eye. And medially, it's it's the medial aspect of the root of the nose on the left side, and laterally medial canthus of the left eye. The edges are raised and beaded, margins are irregular, and the floor appears to be hyperpigmented. The surrounding area, there is no redness or pigmentation, sir. Palpation, all my infected findings were confirmed. There is no warmth or tenderness in the surrounding skin. The edges are raised and beaded, and the base is indurated. The ulcer doesn't bleed on touch, and it's mobile in all directions. It's not fixed to the underlying skin, and there is also no loss of sensation. There is no enlarged lymph nodes. Systemic examination, cardiovascular system, S1, S2 here, respiratory system, bilateral air entry is present. There is no added sounds. Per abdomen is soft, and CNS, there is no focal neurological deficit. The summary, Mr. X, a 76 years old male, diabetic and hypertensive patient belonging to a lower middle socioeconomic status and a farmer by occupation, presenting with a complaint of ulcer of 2 × 2 centimeter in the middle canthus of the left eye with the averted and beaded margins for the past 3 years and associated with itching, which was aggravated for the past 3 months. I would like to come to a provisional diagnosis of a cutaneous malignancy, probably a basal cell carcinoma, sir.
Okay, Monica, why are you specially telling about diabetes and hypertension for this case? Do you think they play a part in the etiology of BCC?
No, sir, but presence of diabetes makes him an immunocompromised person, which may add to the progression of the disease, sir.
So immunocompromised patients are more prone for BCC?
No, sir, they come under high risk category.
Okay, maybe, I don't know. Now, second thing you said.
In your summary, you don't need to put that. Sir is telling you.
Yes, sir. Okay, yes, sir.
Now, what other things, what are your points in to say it is a BCC?
Initially, it's the location, sir. It is present in the middle, near the middle canthus of the eye, which is the most common site for BCC, sir.
Do you know of any particular line there?
It's Ongren's line, sir. It's the line joining ear lobule and the angle of the mouth, and the lesions of basal cell carcinoma, they usually lie above this level, sir.
Okay, no, you said no lymph nodes. So
Yes,
it's
sir.
a very general used. You are not, you should have specifically told which lymph nodes to examine in this case. You said no lymph nodes. I don't know what exactly you mean by lymph
No preauricular or submandibular lymph nodes, sir.
Preauricular, and can you tell me the cervical lymph node? Submandibular should be more specific. This is the 1A or 1B or 2?
Sir. 1A, sir.
1A is submental, am I right?
Yes, sir.
So you should always use those words because don't tell like an undergraduate. As a postgrad, you should be a little more specific about your presentation.
Yes, sir.
Now, what other things make you diagnose a BCC? Why not it is a commercial custom also can arise there?
So no lymph node involvement, sir.
What?
So there is no any lymphadenopathy, sir.
No, not necessary. Just because you know lymph node enlargement, you want to look at a BCC. There can be SCC also without lymph node enlargement.
Yes, sir.
Other than your site, that's specifically about that triangle, about that, whatever it is, that other than that, what other points for you clinically to say, other than the site, to say it is a BCC?
The characteristics of the ulcer, sir. The presence of beaded and rounded edges, sir, and the center presence of hyperpigmented floor, sir.
Hyperpigmented score has nothing to do with BCC. Yes, then?
Yes.
The edge may be very important, yes. Site and the edge, then?
Yes, sir. Duration and it's being a painless for a painless ulcer, sir.
Painless ulcer, all malignant ulcers are painless. All malignant are painless. Not necessarily. All other names of BCC?
Rodent ulcer, sir.
Then? Do you know of any clinical subtypes of BCC?
Nodular type, cystic type.
Very good.
Then geographic or field fire. Then morpheal type.
What is that?
Morpheal.
Okay. Yes. So why we don't see lymph nodes in the BCC?
The malignant cells are usually large enough to block the lymphatics, sir. So there is no lymphatic spread, sir.
Is undulation a feature of BCC?
No, sir. It's not a feature of.
Undulation is present in this case.
Yes, sir.
So why it's not a melanoma? You said pigmentation is there.
Yes, sir.
I could have made a diagnosis. You could have made a diagnosis of a malignant melanoma. That what you said, so-called pigmentation, maybe something like black pigmentation, which is a feature of melanoma.
Yes, sir. But there is no lymphatic spread, sir.
There it's more important.
Yes, sir.
Not in HCC. Melanoma, 3 months duration, no melanoma keeps quiet for 3 months.
Yes, sir.
That's very, very important point there.
Yes, sir.
Very important point. So how do you proceed in this case?
So you can proceed with the edge-wedge biopsy, sir, and the CT scan of the local part, sir. Biopsy by edge-wedge. In this case, if further proceeded with the biopsy and the diagnosis is confirmed, they can go with wide local excision with 5 mm clearance, sir.
I don't want surgery. If I'm the patient, I don't want surgery.
Sir, depending on the location by the least ulcer being.
Your case, don't say depending on the site. Don't talk about theory. You
Yes,
have
sir.
got a case with you. You have presented a case. You told me
sir.
this site. Now
Yes,
your case. What is treatment for this case? Don't say depending on site I will do. Depending on that I will do that.
Cryotherapy or laser. Sir, cryotherapy or laser, CO2 laser.
What is second line of treatment for skin cancers anywhere? Why not radiotherapy?
So it's near the eyes, presence of location near the eyes, nose.
Very close to eye.
Yes, sir.
But that's not an absolute contraindication.
Yes, sir.
Monica,
Yes, sir. Yes, sir.
what is the histopathological finding in basal cell carcinoma?
There is nuclear cytoplasmic ratio is increased, but there is no mitosis is seen, sir. High.
There is a classical thing called
feature.
Characteristic features, as Harindra says.
That is not present. You should say what is
A
present.
palisading pattern of cells.
Yes, yes. That is where I am going. What is a palisade? We commonly say peripheral palisading. Am I right?
Yes, sir.
What is a palisade?
It's like a fencing, columnar cells arranged closely.
Yes, you are good. Too good.
Yes.
It is something like a fencing, railway fencing. Have you seen a railway fencing?
Yes, sir.
It looks like a railway fencing. That is why we call it as peripheral palisading.
Yes, sir.
Okay.
Yes, sir.
That is a classical finding of BCC, basal cell carcinoma.
Yes, sir.
Good.
Yes, sir.
What is the, see, you have done, the patient has undergone surgery.
Yes, sir.
Okay, the margin is microscopically positive. What is the danger associated with this?
Recurrence is highly seen if the CA is not removed without any marginal clearance, sir. And the recurrence will be aggressive, sir.
Yes, it is very, very, very aggressive. The patient may lose even the nose or eyes, something like that. The first surgery or the first treatment, whether it is radiotherapy, cryo, whatever it is, it should be the best and it should be done appropriately to prevent future recurrence. Recurrence is one of the worst thing in basal cell carcinoma, though it is an indolent tumor. Recurrence is such a dangerous thing. Yes.
I've heard of a pigment.
Sir? Sorry, sir, it's not audible.
Pigment.
Pigmented BCC.
I've heard of
Sir?
Because you were talking about pigmentation in your presentation.
Yes, sir.
Just like a melanotic melanoma, there is also a pigmented SCC, pigmented BCC.
Yes,
But I don't want you to straight away commit in the examination. It's a pigmented basis.
Yes, sir.
So that will come only during discussion.
Yes, sir.
Over smart and say and commit and say pigment basal carcinoma.
Yes, sir.
So that should come as your defense order, defense answer. If the exam will ask you why the pigmentation.
Yes, sir.
What are the other cutaneous malignancies you know of?
Sir. Sorry, sir. It's not audible, sir.
See, what are all the cutaneous malignancies you know?
Cutaneous malignancy. Other than BCC?
Squamous cell carcinoma, sir. Melanoma, sir. Pre-malignant conditions like keratoacanthoma, seborrheic keratitis, sir.
Can you talk something about Kaposi sarcoma? Kaposi sarcoma is associated with which condition?
Herpes, sir.
Herpes. Rampant. The government is spending big money for that. HIV.
Yes, sir.
HIV, the two in a later stage, 8th stage. Kaposi sarcoma is common.
Yes, sir.
Okay.
Yes, sir.
You said squamous cell carcinoma, basal cell carcinoma. What else? Other malignancies?
Melanoma, sir.
Melanoma.
Yes, sir.
You know, Marjolin's ulcer.
Yes, sir. This type of squamous cell carcinoma occurring in a long-standing non-healing ulcer, sir.
What is the difference between a Marjolin's ulcer and a de novo squamous cell carcinoma?
Will you get lymph nodes in Marjolin's? Will you get lymph nodes in squamous cell carcinoma?
Yes, sir. Lymph node involvement is there in squamous cell carcinoma, sir.
But in Marjolin's?
Marjolin's, there is no lymph node involvement, sir.
Why?
Because of scarring and desmoplastic reaction, sir.
Yes, scarring is there, so all the lymphatic channels are blocked.
Yes, sir.
But you get a lymph node enlargement in a Marjolin's ulcer. What do you think it is?
It's secondary, any bacterial infection, sir.
One is bacterial infection. Number two is the malignancy has crossed the border.
Yes, sir.
Are extensive. It is not into the normal skin.
Yes, sir.
You may get a lymph node enlargement.
Yes, sir.
Okay, sir. Colonel.
Yes, sir.
Other parts of site you said, can a BCC occur in any other parts of the body?
Yes, sir. It can occur in mucocutaneous junction, sir. Any mucocutaneous junction, sir.
No.
That is melanomas.
No. Change your answer, please.
Yes, sir.
Yes. Post-orbital region,
lips,
post-orbital region, forehead.
Yes, sir.
No.
Tibia.
So the problem with those rarer sites are they are more prone for recurrence than the classical site.
Yes, sir.
They occur in unusual sites, they are more prone for recurrence.
Yes, sir.
When do you do excision biopsy for a BCC? Very simple answer.
Yes, sir. When
lesion is small.
When it's small, less than.
What is a turban tumor? Have heard of turban tumor?
Yes, sir.
Though there is a controversy about that, but still there is something related to your case. Turban tumor. It's a literally word, turban, something.
With
Supposed to be a variety of BCC. Something like a turban-like swelling over the scalp. Okay, I'm done, Dr. Kanavelu. I think you can ask others.
Yes, sir. Hemant sir, Srinivasan sir, any other questions, sir?
No, sir. If she is willing to ask any question, I
Sir,
think she has covered everything.
Sir, let me tell 1 or 2 points, sir.
Please,
Yes,
sir.
sir. Yes, sir.
So we are discussing about this Marjolins now.
yes, sir.
In Marjolins, as sir said, you may not have regional lymph nodes, whereas
Yes,
in
sir.
de novo squamous carcinoma, we may have lymph nodes.
Yes, sir.
And in Marjolins, we may not have a classical everted edges as if in de novo squamous carcinoma. Why?
Yes, sir.
In classical squamous cell carcinoma, I mean de novo squamous cell carcinoma, we may have everted edges. That is a unique feature of squamous cell carcinoma. Am I right or wrong?
It's because of spreading of the edges.
The same rule applies
Yes,
for
sir.
the lymph nodes. See,
Yes,
why this everted edges in squamous cell carcinoma?
because the cell division occurs peripherally and the marginal cells are spreading and they roll out over the margins and fall by the near tissue, sir.
See, the periphery outgrows the central portion.
Yes, sir.
The blood supply to the central portion is less, whereas the blood supply to the periphery is more. So the periphery outgrows. That's why we get eversion. And the central portion get less blood supply and it may go for necrosis.
Yes, sir.
Okay. The same
sir.
thing applies in Marjolins. The blood vessels, the blood vessels also may get destroyed. So there may not be rapid peripheral growth. So we may
sir.
not have a everted edge.
Yes, sir.
Similarly, we may not have pain also in Marjolins ulcer because of the destruction of the nerves.
Yes,
Whereas
sir.
in de novo squamous cell carcinoma, if it is deep involving the nerve, we may have pain.
Yes,
So
sir.
there won't be any pain in Marjolins ulcer. There won't be any lymph nodes in Marjolins ulcer. There may not be having a everted edge. As sir said, we may have everted edge if the lesion goes beyond the scar and reaches the normal skin.
Yes, sir.
Similarly, we may have pain if the lesion reaches the normal skin.
Yes, sir.
Okay. Let me conclude. Monica, you want to ask any questions? Kanagavel sir said, if you want to clarify any doubts.
No, sir.
Dr. Harindra Sandhu, you have any questions?
Fine, sir.
Hitesh sir, any questions?
No, sir. Fine.
Okay. Lakshman Prasad sir, thank you, sir. Karnakaran sir, Kanna sir left some time back. Hitesh sir, Srinivasan sir, Harindra Sandhu sir, everyone. And I also thank the professors who contributed today's case. Professor Srinivasan sir, Professor Sumati madam, Dr. Raj Ashok sir, and then Professor Alex Edwards sir and the entire team. I also had congratulate the team of students, Dr. Nizam, Dr. Monisha, and Dr. Monica, for spending their valuable time with us. And I also thank all the professors, faculty joined us today, and all the students who have been watching both on Zoom and YouTube also. Thank you very much. And I'm happy I'm receiving a lot of students telling that they have passed the exams. So very happy for, and I also put my thanks and sincere respects to all the senior faculty who have been contributing over the last 150 classes we are touching. So I'm sure this will be a definite what is a proud moment for all the faculty who have contributed, and of course the students. Without students, there is no PG clinics. Thank you, students, for allowing everyone to learn out of your efforts.
And
So,
our wall around which we all rotate our strike. This is our wall.
Yes, good
Yes.
DNB results today, sir.
Yes,
You
sir.
know, and they almost 90%, more than 100% pass rates.
Very good.
many people have got good results.
Good results.
So, Sandhu,
Sir's voice.
Voice
Yes,
was
yes.
breaking.
Thank you, Sandhu, sir.
Thank you, sir. Thank you, sir. Thank you very much, sir.
Thank you, Kanavel, sir. Thank you, Hitesh. Lakshman, sir, namaskar.
Thank you. Thank you, sir.
Pranam, sir. Thank you.
Thank you, sir.
Well done, Monica, Nizam, and Monisha.
Thank you, sir. Thank you.